this is our hospital, not a fancy building like your building there. But we have here the Alexander Fleming's stone, actually. Hang on. And that is his lab, which is now the museum. So the foundation stone of the hospital was laid 28th of June, 1845 by Prince Albert. So that is me. I'm general radiologist, but then subspecialized in pediatric and do a lot of musculoskeletal imaging. That is kind of, you can see then where I'm coming from with the talk. As Woody explained, the kind of clinical challenge that we have in MRI and imaging of MRI is always the trade-off that you have between how you get your resolution, how improve your signal to noise, and keep your timing low, and then the consequence of that, which are a lot of different type of artifacts. So pediatric radiology and pediatric imaging is slightly more challenging. Also, you have additional issues when considering that you are scanning children from, let's start with preterm children that we have here from age 23, 24 weeks till 18 years of age. And then, of course, additional to those kind of challenges on a daily basis, you have then the compliance with of the children, which is, of course, age-related usually. Sensitivity, more sensitive to noise. Children are afraid of noise, and inability to keep still even for older children. Size, of course, if you consider a kind of 23, 24 weeker is 350 gram. And as a kind of consequence of all of these things together is then you have suboptimal resolution, suboptimal images, and then the need for repeat scans. Some of these scans are under GA, under sedation that you have to repeat, and or using other cross-sectional imaging, for example, CT scan, which includes radiation. And again, that is a big topic. You can write a talk about that with all of the cancer risk and accumulative dose that you have then in children, which is, again, different from adults. So magnetic resonance imaging, therefore, of the pediatric population as a whole, and specifically in this case, the musculoskeletal system, is therefore significantly different from adults based on the circumstances that you have. And then if you include the pediatric pathologies, that is, again, another type of imaging. So the differences between pediatric and adult, a lot of that is based on the differences between the skeleton. Also, children are not small adults. You have, of course, difference in skeletal proportions. You have cartilage content, which is completely different to adult, and the composition of the cartilage. Bone marrow composition in similar way, and changing bone marrow, which is age-related, chronological, but also gender-based. The same way vascular pattern and changing vascularization and trabecular organization, which is also changing with changing trabecular appearances based on the weight-bearing axis, which is age-related, and then going back to the skeletal proportions. The presence of course, growth plate and the growth process itself. Not to forget the neuromuscular differences, which is evolving through the childhood with different muscular bulk, strength, and changing of the position and the type of the weight bearing. And all of these things rapidly changing from age 0 to age 18. So this is a picture or two pictures from Keifi's textbook. On the left-hand side here, you can see the structural skeleton or bone of a tibia in a young teenager, and on the right-hand side, you can see the changes of the skeleton or bone of a tibia from a fetus here, which is a pulp of cartilage, to a formed bone in the middle-aged kind of teenager. That with the start of the ossification in the center of the bone, and then transforming the pulp of the cartilage to what we see is nearly similar to an adult bone. So this is a T2 fat set chronological series of the lower limb, starting from at the top here, age 1.5 months to 16 years. And you can hear in kind of imagine how is the development in relatively this short period of life, with the development of the cartilage, the evolution, and you can imagine the difficulties of imaging these joints with the different interfaces, for example, just on a tiny joint. So pediatric skeleton contains more cartilage. Initially, it's just a pulp of cartilage in comparison to adult, and a growing skeleton has different interfaces at the joint level. And the cartilage is, to make it even more difficult, is not just the one type of the cartilage that we have in adult. There are different type of cartilage that you have in the same bone, layering over each other. So the different type of the pediatric cartilage is varying, however, in tissue matrix, which is a kind of glucosamine, glucane, and has different content of water, which of course is useful in a way. In a way is causing you difficulties in artifact, but if you know how to use it, then potentially you can gain actually contrast for MRI. So this is an example of a pelvis of a primary school child. On the left-hand side, you have the 3D merge sequence, and on the right-hand side, there's a T2 fat set. And specifically on the left image, in the merge image, you can see the different layers of non-bony tissue just around the joint here, and how much different kind of, let's say, tissue information on one hand you have, and the other hand, trouble with the imaging and the potential for artifacts. In the same way, the pediatric bone marrow is, of course, different to the adult and is changing chronologically. The pediatric bone marrow is rich, and a red marrow is changing gradually towards the fatty bone marrow in adults. And is a chronological change. It is gender-based, so it's different between boys and girls. And the MR imaging is, the interpretation of the bone marrow is very difficult but very useful. If you have the knowledge of the changing of the bone marrow in the different age group, then you can use that for your diagnosis, and B, even in advance in preparing, in planning the protocol for the study, once you know how old is the child, once you know the gender of the child, and of course the clinical indication. So this is a similar T1 kind of series, chronological series, again starting age here 1.5 months to 16 years of the lower limb. And you can see that the child here in 1.5 months, it's just the gray in gray. Also muscles are gray, bone is gray, everything is gray apart from the subcutaneous fat tissue. And that is the red marrow. And then already 11 months later, it's looking different. And then if you go through the series to the last image, which is nearly similar to an adult image then, that happens again in that relative short period of time. So to make it, again, more difficult, the vascular pattern is the same. You have the vascular pattern, which is in the first few months of life. Then you have different vascular pattern till age 1.5. And then from 1.5 to mid, kind of late teenage years is the same. And then after that, you will have, again, a change, which is then the final adult version of the vascular pattern. Here on the left-hand side is a image that's showing this is a child age above, or is a bone age above 1.5, where you have the growth plate separating the vessels, or causing two different path branches for epiphysis and metaphysis. Till that age, you have a central vessel which is going through the growth plate, and then from mid 1.5 years, let's say, age, you have this separation through the growth plate. You have the rich capillary bed here, which is much more than in adult. Therefore, if you compare, for example, adult metaphysis with adult pediatric, you will see that in T2 fat sat sequences, the pediatric metaphysis is much more hyper-intense, which sometimes causing issues that some of my adult colleagues, they say it is edema there, which is actually not. It is the normal appearance of the metaphysis. So, and here is a T2 fat sat sequence. This is a gradient echo post contrast, and you can see the central canal with the central nutritive vessel in T2, better visualized here in the post contrast. And then you see the tiny vessels which are separately going to epiphysis and metaphysis. So Pediatric musculoskeletal pathologies are also far beyond the pathologies that you have in adult. You have nearly all of the adult pathologies in pediatric, but at the top of that you have then the congenital abnormalities. You have the neonatal abnormalities, so like DDH, etc. And then you have the childhood-specific traumatic pathologies, which you have a trend which is slightly separating between the age group. Also, you have traumatic injuries below the age 3 to 5 and above that, and then you have traumatic pattern of injury, which is partially gender-based, also male or female injuries. And of course, you have also the childhood-specific non-traumatic pathologies. So the magnetic resonance imaging of the pediatric population, therefore, or musculoskeletal system, is actually far beyond the adult. It means if you think the MSK imaging of adult is difficult or complex, pediatric is another layer, and it's far above that. So it means more protocols, more sequences, but also more opportunities. So what I have was, for me, always interesting in MR was that in MRI imaging, every obstacle or handicap, it's obscuring actually behind it an opportunity. It means the difficulties and the problems that you have are not pure problems. If you manage to resolve that, then you can see actually a benefit and an advantage in imaging. So the solutions of kind of dealing with the daily problem of a trade-off between signal to noise, between resolution, artifacts, scanning times, etc. As Prof. Gedroich said, it's kind of the 3 different type of hardware solutions: higher strength, stronger gradients, software solutions, and adjustment of the acquisition parameters. So we all do that. We all every day dealing with that. However, this costly kind of balance between signal, resolution, scan time, and how to deal with artifacts is helpful, is improving, and we all work on that. But still, we didn't have these solutions to remove all of the artifacts and have improved images significantly and fundamentally. We started years ago to work with our engineers here and the application specialists, and tried to come up with some local improvements. So started doing fine-tuning of the sequence parameters, introducing or using faster sequences, specifically focus on for pediatric imaging with faster sequences, improving a mix and match of sequences and plane in order to combat handicaps of one sequence through the signal that you get through another sequence, and with putting different sequences next to each other, improve the conspicuity of the pathology and the diagnostic confidence of the radiologist. So a lot of other things like changing reconstruction parameter of volumetric imaging, inversion, adding some sequences which are not necessarily, or it used to be not, pediatric musculoskeletal or at all musculoskeletal sequences, such as diffusion-weighted sequences, T2 star, volumetric gradient echoes, and then even pre and post contrast sequences with subtraction, dynamic contrast enhancement, and serial contrast enhancement, to use and try to use all of the kind of arsenal of MRI with qualitative curves, semi-quantitative values, or even quantitative information from the dynamic series. So these are 2 examples from what we have achieved. What we can see at the top is a child with osteomyelitis or septic osteoarthritis of the knee, and this is the T2 sequence, T1 post-contrast and subtraction of was a dynamic series actually, post-contrast subtraction. And this is a reconstructed, reformatted, and inverted DWI image. And the second series is the osteomyelitis of the tibia. Again, same T2, it's the T1 post-contrast and subtraction of the dynamic post-contrast. And again, the reformatted, reconstructed, inverted image from the DWI. So we managed to improve the amount of the information. We managed to kind of create a complementary protocol that the sequences complement each other, and you get the information somehow out with improving the diagnostic confidence of the for the radiologist. Also, the diagnostic confidence and conspicuity improved, but then at the cost of course, time. And consider all of these patients are pediatric patients. So we did improve. However, it couldn't change the daily still problem with signal to noise, resolution, field of view. As soon as you have this protocol, you think you have achieved what you wanted. Then you sit there and then looking at the wrist of a 3-month-old baby and the size of that. And as soon as you match the field of view, then you lose your signal to noise. It's not acceptable. Resolution, you can't see anything, and you can expect artifacts there. So improved, but not enough. At some point, it was kind of in a desperate situation. They say, okay, we did what we could, but that's it. So you can't improve beyond this with the kit what we have. And it was more and more apparent that just sitting in the cycle of the interdependency of all of these parameters and going from one parameter to the other one and try to kind of adjust a little bit to get more than that, it has its limits. And at some point, you go in the cycle and actually you are not achieving much more. So it was kind of obvious it has to be something from outside. Something out of this cycle has to come and help. Something has to come, the magic has to come from outside to break this cycle. Some kind of creating in a different way signal, harvesting signal in a different way, reconstructing the different way the signal, or maybe all of that together. So at some point we did said, okay, that is something that must be some way of AI being able to help and to be able to bypass the interdependency cycle between all of these parameters and create for us, give us that what we want. However, we didn't calculate with something like, or I didn't at least, with air recon. I think Woody said the same thing, that if you would have asked him a year ago. So why? Because I did think about that there is a way with AI, with deep learning, that you can improve, for example, the resolution. You can improve the resolution or signal, but not being able to kind of parallel reducing the time. So, as mentioned before, the air recon deep learning technology which is an AI technology, is reducing your scanning time, reducing the artifacts or removing your truncation artifact. Through the reducing scanning time, you are in a pediatric population, you are removing more or less the motion artifacts. Also, it doesn't have any direct reduction of motion artifact, but through reducing the time, you improve the compliance of the child and the motion artifacts. So, of course, higher signal to noise, very useful, especially when you have to reduce and have small field of view, higher resolution in the same way, and the ARDL sequences that we use, if you compare with the same sequences, if you have or try to get close into scanning time, you will have much quieter, or we have much quieter sequences, which is significantly important for pediatric patients, those who we try to encourage to have the scan without GA or sedation, as noise is a big factor for pediatric population. So the air recon technology has kind of addressed a lot of these issues that I said. For example, improving compliance and motion artifact through reducing scanning time, or improving the conspicuity of pathology through improving signal to noise. The same with the resolution, and bear in mind, improving the resolution and signal to noise means that you don't repeat the scan. It means you don't need to have multiple follow-ups or using another cross-sectional imaging to combat the difficulties or handicaps that you have in your MR imaging. So reducing sound is again improving the compliance significantly, and truncation artifact helping to improve the small field of views for neonates and smaller children. The improved diagnostic quality at the end has significantly improved the number of scans that you have to do, for example, in cases that you have not a clear outcome. diagnostic outcome, and that is improved significantly with reduced number of scans. At the top of this is general more or less for pediatric population. The effects that are specifically important for pediatric musculoskeletal imaging is one, the cortical and trabecular structure of the growing skeleton. The cortical and trabecular structure is very important, much more important than adult, because there are a lot of pathologies, pediatric specific pathologies that start with mild and subtle changes in the bone trabecular structure or bone marrow. If you know how is age-related and gender-related the normal bone marrow and the trabecular structure, that is a big help, because then you can pinpoint the early changes in the pathologies. So starting with hematological disorders, stress fractures, changing in neuromuscular development, causing abnormal gait or abnormal weight bearing, and abnormal weight bearing is causing changes in the trabecular axis and the pattern of the trabecular axis. Therefore, the trabecular bone, the trabecular structure of the bone is very important in pediatric musculoskeletal imaging. However, the trabecular and cortical structure was not kind of necessarily a strength of MRI, and the artifacts, or even the normal without artifact images, they never had created a nice trabecular structure, and therefore in some cases we were forced to do CT in order to see the bone marrow and to see the bone trabecular structure better. This is an example now. On the left-hand side is ARDL, right is the same sequence as conventional. And if you, it's T1 sequence, by the way, if you compare left and right, you can see what I'm talking about regarding the trabecular appearances. For example, if you look at the trabecular meshwork here, or the trabecular in the epiphysis there, and compare it with the right-hand side normal conventional sequence, or the pathology here at the tip of the distal tip of the patella, and then compare it with the clarity and the sharp edges, how the trabecular structure is interrupted there, the changes in the Hoffa's fat pad, or the proximal aspect of the tendon even in a T1 sequence is significantly different. So Ericon has improved this through sharpness, improving sharpness, reducing truncation artifacts, increasing the signal-to-noise ratio, improved significantly the clarity of the trabecular structure, which makes it much easier in describing or detecting, let's say, early pathologies in the bone. So cartilage composition is another piece of information which is improved by Ericon deep learning software. So the cartilage, as I mentioned, the cartilage in epiphysis or around joints is a multi-layered cartilage, different type of cartilage. You have hyaline growth plate cartilage, you have fibrocartilage, and then you have, again, hyaline articular cartilage, which is very difficult to dissociate and differentiate if you don't have the good resolution, and if you don't have this separation, then you cannot say if the growth plate is involved or not, how is the prognosis, if is that going to impact the ossification center, for example, of epiphysis, or the growth of the child, which is very important for follow-ups in a growing child. However, again, in this case, the cartilage was not necessarily, the quality of the imaging was not good enough to be able to do that. And specifically in younger children with small field of view, this is more difficult. But bear in mind that the younger the child, the more cartilage is there. It means exactly the group, the type of part of the population that we want to see more from the cartilage, that is the part that we can't see because of the difficulties with signal, artifacts, and small field of view. So this is now a comparison between left is ARDL, right is the same knee, conventional, and then again, if you look at the cartilage layers here you have the growth plate of the distal femur, then you have the cartilage, growth plate cartilage of the ossification center, the fibrocartilage around it, and then the articular cartilage at the top, or the retropatellar cartilage and the depth of the cartilage. And then if you compare that with the conventional image, you see a significant difference there, which is not really clear. You can't see the different layers of the cartilage, and best case scenario, you can say just there are changes. And funny enough, in this case, I would have said that in this image, I would have said there is slight thinning of the retropatellar cartilage, which, however, when you look at here, you see actually the bulk of the cartilage is completely normal and it's not thin. It just appears like that. So there is a significant improvement in these two images. And if you take it and compare it with adult, I would say there is much more beneficial actually for pediatric musculoskeletal system than adult. It is helpful in adult, we know that. But even in pediatric is a layer at the top of that, and the improvement and the additional diagnostic confidence that you have is much more when you compare with adult using ARDL or conventional imaging. So the application has, as I said, significantly improved the conspicuity of the varying level of the cartilage, which is then helping to dissociate and see what is what and where is actually involved in the pathology. All of the different interfaces of the cartilage, synovium, soft tissue, fat tissue, for example, let's focus on a knee joint. If you consider how many different types of the cartilage are at the level of the distal femur condyle, with retropatellar cartilage, with the Hoffa's fat pad, with the ligaments and the synovium there are multi-layers of non-bony tissue which can cause difficulties with imaging, but be also confusion with reporting. So definitive ARDL has improved the separating this and dissociating these different soft tissues or not bony tissues from each other, and trying to make sense out of this complex and try to kind of map that and try to find out that the pathology that you see, where this pathology actually is from and where is the extension of that. This is again another knee, and if you compare the left, the ARDL image, and the right, the conventional image, you can again see, for example, if you go to the level of the joint or here, you see the collateral ligament nice and tidy there. You see slight edema and pathology there. You see the separation of the medial meniscus and the attachment to the medial band. All of these things, if you look at, sorry, I will hold it's not as clear here. You can see the kind of vaguely the collateral ligaments, but then all of the other things is just there. When you report, if you have that aspect, if you have the image on the right, you will say something, as Woody said, you will say something vague because you can see something, but what is it? And if you want to pinpoint it, you are not comfortable to go farther and say, oh, it is actually this and that, and you make it a little bit more general. It's definitely helping your diagnostic confidence and your report at the end of the day based on that. So on one hand, the AI technique and the development that in the software that I have shown, for example, with the ARDL, it is a huge change in our practice as a pediatric radiologist. It is more or less completely changing how we operate. So an ARDL is just the beginning of this AI intervention. There are many other applications that are in making or are there that kind of needs fine-tuning, needs revalidation, etc. But they are available. As an example, for example, the 0TE-MR and kind of TE0 application that with AI-supported machine learning or deep learning reconstruction post-processing application, you can use and create 2D and 3D isotropic images from bony skeleton, which is a significant milestone for pediatric radiology. Here there are some examples. If you, for example, look here, this is a C-spine. On the left-hand side, you have the CT image, and right is MRI. So this is MRI, and it's not a CT image from the shoulder joint, and the same shoulder joint is reconstructed. So it means you can create a 3D image from the MRI image that you do, exactly the same as CT. And this 3D image you can use it for 3D printing if you want to do a prosthesis, for example, for the joint. All of these things available just with one MR sequence or one MR imaging. This is a fracture, left hand is CT and right is the same as a MRI fracture of C2. Clearly visible, even in a traumatic case, in a trauma case, you can use that. So considering both these two things that I've discussed, ARDL and the benefits that you have for pediatric musculoskeletal imaging, and then additionally at the top of that, this 0TE, you can include all of these things in one protocol, which is, if you compare with our conventional non-enhanced protocol now, this will be much shorter, by far 15 to 30% shorter than what we have. So you reduce time for a pediatric population by, let's say, 15 to 30%, and then create this kind of improved and advanced images, plus CT bony reconstruction, which means that patient, for example, if it's a tumor or if it's a kind of benign lesion that you need to go and have MRI and a CT scan, 2 examination. You don't need 2 examination. You don't need 2 appointments going to 2 different examination. And most importantly for pediatric population, we have to be very mindful with radiation. Radiation dose, even if it's a low dose CT, the radiation dose that you will save for that child with the accumulation dose and the cancer risk long term. So this is definitively changing our practice, as we did some years ago, that we reduced gradually more and more nuclear medicine out of the pediatric imaging and replaced the nuclear medicine necessary imaging with MRI, increased the MRI and reduced nuclear medicine in order to save the radiation dose of the nuclear medicine. In the same way, this is a way forward to replace CT examinations with MR and have a complete radiation-free kind of diagnostic, whatever clinical question it is. So as a conclusion, therefore, I think AI-related MRI solutions are A, very exciting, B, the future or the existing future around us, and not only will bypass these kind of daily problems with barriers that we have with trade-offs, etc., but will completely change how we operate. From the operational point of view, you can also imagine that if you reduce 1 tear of the imaging diagnostic of a child, which is, for example, CT, if you can do all of that with one modality, you have a one-stop clinic or one-stop diagnostic, and you have completely removed for our managers or operational team to have to create different folders, different patient list in order to have MRI and CT. You completely remove that at the top of the benefits for the patient and at the top of the improved diagnostic confidence for the radiologist. So this, and of course, here it's kind of a review again of the changes that ARDL brought already to our daily operation, reducing scanning time. We get more patients through, less motion artifacts and improved kind of compliance of the patients with higher resolution, higher quality images, and removed, of course, truncation artifacts. So therefore, it was definitely a winning factor for us, and we're looking forward to the further developments, including, as I said, for example, the bone imaging and replacing CT with MR. Thank you very much.